Okay, so good morning to everybody. It's really a pleasure to introduce Dr. Richard Wynn and to welcome him to our department. He's now a voluntary professor in our department, having moved to this area. Uh, Dick really needs no introduction in neurosurgery, certainly to those of us who've been around for a while, but since some of you residents and younger faculty may not be as familiar with his background. I'll give you a little bit of a background. Dick really has a kind of an Ivy League background, having gone to Princeton for undergraduate and then University of Pennsylvania for medical school. And then after an internship in Cleveland, he went to the University of Virginia, where John Jane was creating one of the foremost residencies, most distinguished residencies in the country. As part of his training in neurosurgery at the University of Virginia, it was the tradition then and has continued to be to this day. I think that was instituted by John Jane to send the residents to England for 1 or 2 years. To get a tremendous independent operative experience in England as registrars, and also many of them as they did research, clinical research, and some of that research that he did in England during those 2 years may have formed the background of this talk that you're going to hear today on the natural history of cerebral aneurysms. Dick rose to the rank of professor and vice chairman of the department in a short 5 years from having finished his residency, which is remarkable. Quickly became the indispensable man in Virginia and Dr. Jane's right hand. And then he went to Seattle as professor and chairman at the University of Washington. At that time, the University of Washington was really known for its work on epilepsy and functional neurosurgery, and there really was no interest on vascular disease and aneurysms and so forth. And over a period of just a very few years, Dick built up one of the largest aneurysm practices in the country, and he did that initially by being on call by himself every night and getting up and doing early surgery. One of the early people doing early surgery in aneurysms by himself, until he was gradually able to recruit some people and make the University of Washington a powerhouse in vascular disease. Throughout this time, Dick has done research, and in fact, he had uninterrupted research support from the NIH as an R01 principal investigator for over 20 years, working mostly on cerebral blood flow and the regulation of cerebral blood flow by adenosine. And as part of his research, he became a Jacob Javits investigator, which is really one of the greatest honors that a clinician doing research can obtain. After over 20 years tenure at Washington U, he moved to New York, where he became and continues to be professor of neurosurgery at Mount Sinai Medical School. He is also professor at the University of Iowa and at Kathmandu. And some of the younger residents may not know what Kathmandu is, and I certainly haven't been there, but it is the capital of Nepal. Dick has just won so many awards nationally and internationally in neurosurgery that I can't begin to name them all. But I'm sure that one of the things he's the proudest of is to have become a fellow of the American Association for the Advancement of Sciences and to have won the Grass Foundation Research Award of the Senior Society. That's the biggest and most prestigious research award that a neurosurgeon that has a continuing history of doing research can earn. Interestingly, now that Grass Award has become the Wynn Award, thanks to Dick, and continues to be given to one neurosurgeon every year, and we're hoping that our own Alan Levy, who richly deserves it, will get the Win Award very, very soon. Dick has written over about 380 refereed publications. It's an unbelievable record. He, of course, served in the study sections of the NIH and was chairman of Neurology Study Session B, where incidentally I served for a few years just after you, Dick. He's been very involved in the editorial board of Neurosurgery, has been chairman of the editorial board, and has continued to work with John Jane on the journal for a long time. I think his greatest achievement, I'm sure he's the proudest of now, is that he has been for a few years the editor of the standard, really standard textbook in neurosurgery from around the world that began being edited by Dr. Yeomans, and now is the Yeoman Win textbook of neurosurgery with 6 volumes. All of you really live by this book. So it's really with great pride that we welcome you, Dick, to our faculty at the University of Miami. I think you are clearly enriching our faculty, and we're delighted to have you in South Florida. So with that, please.
Thank you, Roberto. I hope my sound is on.
It's perfect.
Yeah, you can hear me. Well, thank you for that nice, and especially thank you for your friendship and support, you and Debbie, over many, many years. And I want to thank Alan for his welcoming me and the faculty to the department. And I also Howard for helping me arrange this, but especially a thank you, shout out to Iggy for his technical support in getting me to do this in a hope flawless mechanical fashion. But just a quick word on disclosure. So over the years, this particular aspect that I'm going to share with you has had support from the NIH, the American Heart Association, and in the UK from Burroughs Wellcome Trust and the Newfield Foundation. But where support was most meaningful were, two folks here. Roberto nicely reviewed and mentioned John Jane's involvement, not just in the natural history, but also in my career. But I want to acknowledge Alan Richardson, who succeeded Sir Wiley McKissick as head of neurosurgery at Atkinson Morley's Hospital, which at the time was one of the busiest neurosurgery centers in the world and still remains very active. But for the cooperative study, as you'll see, which was finished in 1996, that involved 35 centers around the world, the AMH, as it's known, contributed 20% of the total number of cases. It was not infrequent for this hospital to see 600, 700, even 900 aneurysm patients a year, frequently half randomly allocated to bed rest. So here's a quote from a paper we wrote in 1977, not 1877. And that is that although cerebral aneurysms were first recognized in 1761 by Morgagni of Padua, the correct management of this potentially lethal lesion is still unclear and depends upon the accurate knowledge of the natural history. This is perhaps less true today, but still the natural history remains to some degree a mystery. And the question is, and some of these comments I'm going to make in my talk really relate to the history and perhaps in further explanation as to why you might even be interested in the natural history in today's modern era of neurosurgery. So just historically, in the third quarter of the 20th century, the natural history of ruptured cerebral aneurysm was a topic of intensive focus related to high mortality and morbidity associated with the treatment of aneurysms and the desire by clinicians and epidemiologists to identify which patients were at greatest risk of suffering a re-hemorrhage. But with the advancements, by that I mean by post-1975, in the diagnosis, anesthesia, and surgery, the risks of treatment decreased, and almost all patients soon were considered to be candidates for direct surgical repair of the ruptured aneurysm. And consequently, within the neurosurgery, neurology, radiology community, interest in defining the natural history waned. But with the advent of CT and MR scanning and the increased ability to discover intact aneurysms, clinicians and epidemiologists again became interested in more accurately defining the natural history with an increased focus on the unruptured aneurysm, or UIA. Remember, there was no way to identify an individual who had an unruptured aneurysm except a brain cutting. So the development of the CT scanner, which by the way, was invented and created in the basement of Atkinson Morley's Hospital, and then subsequently the MR scanner, allowed clinicians to see in living patients those who harbored an unruptured aneurysm. And then most recently, the introduction of cerebral interventional techniques not only added neuroradiologists and vascular interventional neurosurgeons to the interest group, but also made the need for defining the natural history more compelling. This is especially true in defining the long-term natural history as compared to the long-term outcome of interventionally treated aneurysms. And I'll touch on that towards the end of my talk. Well, as Roberto kindly mentioned, the editor-in-chief of Yeoman's Win, and most of what I'm going to say today is contained in this chapter in the 8th edition, which actually will be coming out in about 20 days, assuming that printing presses are working. And that chapter is the natural history of cerebral aneurysm. Now, for those of you who might be nodding off or not going to listen too much longer, here's the natural history in a synoptic form. And that is shown here by the sword of Damocles. So the natural history of cerebral aneurysms, whether it's the unruptured or the ruptured aneurysm, in regard to when the aneurysm is going to rupture, is defined by the tensile strength of this thread holding the sword that's going to break and drop down and kill Damocles. And the same applies in regard to the natural history of unruptured aneurysms. So a few definitions and terms I'll use here and expand on. The natural history of any disease is defined as the outcome of disease in the absence of any intervention. That's the pure definition. And as you'll see, that can't be totally achieved, especially when it comes to rupture rate. So there are two components that I'm going to divide my talk into two parts. First, the unruptured intracranial aneurysm natural history. Again, that will be abbreviated as UIA. And that natural history of the UIA group can be defined either by the incidence of aneurysmal subarachnoid hemorrhage in the general population, and in most of the time that's expressed per 100,000 population. And then the second way to define the natural history in regard to rupture is the incidence of aneurysmal subarachnoid hemorrhage, not in the general population, but in the UIA population. That is the individuals in the population who are known to have unruptured aneurysm. And that can be abbreviated as the rupture rate, and that the rate introduces a time constant, usually 1 year. And then the second aspect of the natural history is the natural history of ruptured intracranial aneurysms. And the purest definition or defining of the natural history is seen in unselective, conservatively treated patients, that is bed rest patients. And, you know, I was fortunate to have the, to investigate this source of randomized patients to bed rest as part of a host of aneurysm trials done at the Atkins-Morley Hospital in Wimbledon. So as I've already said, I'm going to first deal with the unruptured natural history, and then I'll take up the ruptured natural history. So a few terms. Prevalence. Prevalence is the individuals with a disease in the population at large. So the prevalence of unruptured intracranial aneurysm is estimated to be from 0.2 to as high as 9%. Now the question is, why is there that wide variation? Here's the first table from our chapter, and it shows why this variation is so vast. So probably the major reason that it's this widespread relates to the method of discovery historically. And as you can see with autopsies, for example, here 4 series, Fox from the time from West Virginia, accumulated reports from many studies and found 0.8%, whereas Riggs and Rupp reporting in the late 40s an autopsy series done by pathologists who were really neuropathologists. The neuropathologist hadn't been invented as a term, but they were general pathologists who were interested in vascular disease. So how the aneurysm is discovered can account presumably to this widespread. So another example, radiology, catheter angiography, for example. Here's 2 studies, study out of Japan done in elderly patients over the age of 50, although I would describe that now as being elderly. I would say they're youngsters. But here's a study we did at Virginia, as you'll see, with 4,000 plus patients, and instead of 2.7, 0.65. Well, the difference was these were patients, general patients that came in and was slightly to heavily weighted by trauma patients. And the younger folks in the audience must be saying, scratching their head, what are they doing angiography on trauma patients? Well, remember, there wasn't CT scan or MR scanning, and it was not infrequent that you weren't sure what was going on. Ultrasound, actually a B scan, you'd hold something next to the head and try and find where the third ventricle was to see if it was displaced. But that's how these studies were performed. And of course, that skewed the population to a younger population and might account for the disparity here. Okay, what about prevalence based on populations? And here we see 2 studies, both in Northern Europe, Scandinavia, by almost the same group, but different first authors. One reported in 1998, the other in 2011, and they came up with about the same number. We can round it off to about 3% is the prevalence of intact unruptured aneurysms. And so if you look at factors subsequently studied that are associated with increased prevalence, you see these different potential factors. Gender, females more prevalent, and I'll get into that when we get to incidence. Age, as I've already mentioned, The older populations will have increased prevalence, location, more common on posterior communicating, anterior communicating. Well, I mean posterior communicating in females, anterior communicating mainly in males. Nationality, there's studies that suggest that certain populations have an increased incidence. This again may relate to the method of investigation. Hypertension appears to be a factor in independent gender. And now again, I'm reminding you, I'm talking about prevalence, not rupture of the aneurysm. And there are a variety of biological factors such as wall strength and hemodynamics, genetics, family history, polycystic kidney disease, Marfan syndrome, and lifestyle. So that's few comments about prevalence. Now let's look at a different term, incidence. Now incidence, here's prevalence, here's incidence, and you can see the denominator is different. But prevalence, as I've already mentioned, is based on the population at large. Incidence is based on population at risk or unruptured intracranial aneurysms. And the numerator is aneurysmal subarachnoid hemorrhage. And it's frequently reported out per 100,000 population. What about rupture rate? And I have, rupture rate. Well, rupture rate is, as I alluded to earlier, is the risk of rupture of an unknown, of an intracranial unruptured aneurysm over time. And it's usually, the time period is 1 year. And as with prevalence, there's a wide range in the literature for the incidence of subarachnoid hemorrhage. These differences, again, may be explained by several factors, but here's a new factor. Depends in incidence whether the study's retrospective, where, as Renkel was pointed out, they found less than 1%, but in a prospective study, 4 times higher. Diagnostic accuracy, I've been through this in prevalence, but is the method of detection of CTA, an MRI, or an MRA, or DSA. Biology of the patient at risk. Now we'll dive down a little into the gender issue. Aneurysmal subarachnoid hemorrhage appears to be more frequent in females compared to males, although some studies suggest that females equal male after menopause. Age, another factor. Most earlier studies indicated that aneurysmal subarachnoid hemorrhage increases in age, whereas a relatively more recent study suggests a more complex relationship. That is that males predominate in the younger age, then in middle age, females predominate, and then over 85, males predominate. I think this needs to be substantiated by further studies. Nationality, et cetera, which I covered before, but here's some numbers. This is the incidence of subarachnoid hemorrhage per 100,000. And remember, it could be mixed in these numbers, non-aneurysmal subarachnoid hemorrhage. But in any event, you can see a fair spread, even within 2 precept. In Japan, you have 1 at 11, 1 at 18. I mean, this could also relate to the vigor that individuals applied in trying to find out whether it was aneurysmal or non-aneurysmal subarachnoid hemorrhage. Here's America, one part of America in Massachusetts in the Framingham study. Here's Rochester. And then in Finland, which has been observed in several studies, it's very high. And there's the reversal of the gender spread. So here, females are only at 25 per 100,000, males at 33. And as you'll see, this has been attributed to binge drinking in Finland, which is predominantly by males. Okay, other factors. Behavioral and environmental factors, tobacco, Again, 2 studies, including one done here in Miami, that tobacco smoking has increases the rate. And as you'll see, this has been nailed down further by experimental studies. So there's evidence that causality is involved here. Remember, everything I've said so far is really just observational, not causal. Now, EPIC, again, another report by Conley, the incidence may be decreasing between 1950 and 2005 when this study shortly came out. But as you'll see, other studies are highly supportive of this observation. So I've discussed prevalence, there's a wide range. Incidence also has a wide range. So let's now dive down into what the coin of the realm for neurosurgeons is rupture rate. And that's the risk of rupture of unruptured aneurysms over time. And again, there's wide variation from 0.05 to greater than 5%. And most studies prior to 1998 had settled in at about 1 to 2%, but with a lot of question marks. And this is the table from our chapter, which really I tried to include almost every chapter, beginning with the cooperative study here in 1966. So let's just look at some of these earlier studies. This is Weber's in the New England Journal of Medicine, 1977. He had 65 patients with unruptured intracranial aneurysms that were followed for 8 years and found a 1.7% risk. And there was an increased risk with size and multiplicity. Weber's followed up that study and reported it in the Journal of Neurosurgery in 1987. He added 65 more patients and ended up with 130 patients, and again reported out a 1 to 2% per year. There's a study that we reported in the Journal of Neurosurgery out of Atkinson Morley's Hospital. We had 130 multiple aneurysm patients in which only the ruptured aneurysm was clipped and followed for 10 years. And again, we found a 1 to 2% per year, and the risk was increased by size and blood pressure. And many other studies came up with similar numbers, as I say here. But then in 1998, I assume everybody in the audience was born by then, but there may be some super geniuses in the residency who are younger than that, came out, and it was like a revolution, because what they found was that the cumulative rate of rupture of aneurysms that were less than 10 millimeter in diameter at diagnosis was less than 0.05% per year. I mean, that's significantly less than the earlier studies. And this was a retrospective study of about 2,500 patients done by Weber's. Now, I'm going to go through some numbers here. Really, I just think it's in part fun, but it shows how I would hope people will look at various studies and try and dissect them before widely accepting them. So note in this study that 50% of the patients had aneurysms less than 10 millimeters in size and 50% greater than 10 millimeters in size. But they said 10 millimeters in size, 0.05% per year. So what are the explanations for the disparate observations in the yearly rupture rate reported in the New England Journal ISUIA, and that is 0.05%, and the previous 1 to 2% estimates? And it could be related to bias in the patient selection. New England Journal study was retrospective. and could have been selection. But the same applies to all of the earlier studies. But let's just look at this 0.05% and test the observation that the incidence of rupture for aneurysms less than 10 millimeters was 0.05%, which numerically is 0.0005. So here are some facts based on the same epoch. So at the time, 30,000 patients per year had an aneurysmal subarachnoid hemorrhage in North America, United States, and Canada. 50%, now based on the ISUIA study in the New England Journal of Medicine, which I'm going to refer to as the New England Journal of Medicine article, 50% of these aneurysmal subarachnoid hemorrhages were secondary to aneurysms smaller than 10 millimeters. So in other words, half of this population ruptured an aneurysm that was smaller than 10 millimeters. And we know how the rupture rate is defined by this formula, and let's solve for the population at risk. In other words, number of people in North America walking around with unruptured aneurysm based on the New England Journal article finding. So that is that the rupture rate was 0.0005, and we're going to solve for this. We knew we crank in 15,000 and solve for X. And what this comes back is that in the United States, if this number is correct, there are 30 million people in North America having an intact aneurysm walking around in the streets of less than 10 millimeters in size. But that's not really the denominator. What is the population at risk? Well, to go back here, if 30 million people in North America have an unruptured aneurysm less than 10 millimeters, and the population of North America at that time was 300 million, then the prevalence of unruptured aneurysms, 10 millimeters or less, is 10%. Seems high. So, but we have to look at the numbers a little more closely. And the caveat is the population at risk is not the total population, but those greater than 30 years, or 58% of the population, which means for North America at the time, 180 million, and you put that in the denominator, 30 million supposedly walking around with an unruptured aneurysm. So you would find the prevalence of unruptured aneurysms to be 16.6% for aneurysms 10 millimeters in diameter or less. And that doesn't comport with the earlier numbers I showed you on prevalence. And so, I mean, does that make sense that 17% of the population in North America have an unruptured aneurysm? But remember one thing, we've excluded 50% of the patients who have aneurysms greater than 10 millimeters. So for all aneurysm, that now jacks the number up to greater than 30% of the population in North America have an unruptured aneurysm. So here's a study we did actually in the 70s before the CT scanner was widely distributed. And we looked at the prevalence of asymptomatic aneurysms and we in 450, more than 4,500 and arteriograms. And here are the number of arteriograms. The study went from 69 to 78, and the CT scanner was introduced at UVA right about here. And our review of these 4,568 angiograms turned out there were only 3,684 patients, because in those days, the patient might have carotid angiogram, and it was thought, okay, we can't do the vertebral the same day. So they would come back, and so there was duplication. But we found 24 had an unsuspected unruptured aneurysm, or 0.65% of studied population, nowhere near 30%. And angiography at that time was the gold standard for seeing unsuspected, unruptured aneurysms. But this population admittedly was skewed towards the younger side. So I think the New England Journal of Medicine article, which was quite a revolutionary observation and kind of struck the neurosurgery community as there must have been something wrong. I think selection bias somehow factored into in almost attention bias factored into that study. So let's look at the various factors, and I divided them into aneurysm factors and patient factors and what the known relationship is to rupture. So size, and I'm going to zip through these so that I'm done in time. There's good evidence that the risk is related directly to size with the suggestion of a threshold. And this is a study done in 2012, looking at size in a very large population. You can see here upwards of more than 5,000 patients. And size, here's the larger aneurysms, etc. Next size down. And it seems almost flat. But as you'll see that with more patient numbers and greater intensity, it's shown that even the smallest aneurysm have a small risk of rupture. So small size does not preclude rupture, and I'll get into that in a bit. And here it is, small size. Here's a study in 2019 from the Journal of Neurosurgery. And these investigators from Japan were followed almost 3,000 patients with aneurysms less than 5 millimeters and found that 3 millimeter aneurysms bled at 0.3% per year, 4 millimeters, 0.5. So size appears to have an influence irrespective of the dimensions. Now, question came up about volume rather than size. Here's a study from 2017 by Javella and Korja. They noted that aneurysm volume seemed to predict future rupture. But it turns out, after all, volume is just a product, in a sense, of the dimensions, that volume correlated with maximal diameter, and consequently volume added little to the predictive value of maximal diameter. So size is an important element. Shape. Now, when Roberto and I were in training, the only thing we had to look at was angiography. And Wood reported in '64 that irregularity was involved, was helpful, say, in a multiple aneurysm patient in identify which aneurysm ruptured. So it was not just size, it was shape and irregularity of shape. This was really a prescient observation based purely on angiography. And I think we tend to forget that at times. Now, here's a relatively new factor in trying to identify risk of rupture, and that is the biology of the wall and flow aspects. So wall stress, biophysical aspects, hemodynamic aspects. So these are all properties of the wall or hemodynamics of the blood flow, and they can be computed in shear stress. And these factors now are under intense investigation by a variety of groups to try and determine, find the magic factor that will identify which patients will go on and rupture their aneurysm. I think right now it's not clear in regard to that fact. Location. So it's been known for some time, but was definitely solidified that basilar bifurcation, posterior communicating artery, and posterior cerebral and posterior communicating artery had higher risks. And then subsequently in 2013, a study on the anterior cerebral artery alone found that ACOM higher than those not at the anterior communicating location. And I think a worthy contribution from this study was that cavernous carotid aneurysms and ophthalmic artery aneurysms have a decreased risk of hemorrhage. What about multiplicity? Well, as you saw, studies going back into the 60s and still supported, many studies have suggested that patients with multiple aneurysms have a higher risk of rupture. But the question is why? Is this some congenital abnormality that can be tied down to a risk of rupture that's being investigated? But some suggest that there's a shorter time between formation and rupture, and that may account for why there's an increased risk with multiplicity. Growth. So until relatively recently, there wasn't data that would support what seemed to be intuitive, that growth was associated with risk. And, you know, it's the old saying by Virchow that absence of proof doesn't prove proof of absence. But here's the proof. Here's a study in 2016, which looked at 292 patients with small 7 millimeter or 4 millimeter anterior posterior circulation, and revealed that the probability of growth was about 2.6% per year. I think that's high. And so this may be some sort of selection bias, but it was increased in females, hypertensive patients, dome side, multiplicity, and smoking. And the rupture rate was increased to as high as 6.3%. So, and again, risks were higher in the posterior circulation and lobulation. Now, this has led to, you'll see, a series of suggestions using discriminant function analysis that group things together, various factors. And here's ELAPSE, the ELAPSE score published in 2016, and it's 6 predictors of growth, which in turn then would predict a rupture. And that ELAPSE comes from these initial letters: earlier subarachnoid hemorrhage, location, age, population size, and shape. And as I mentioned, there are other multiple factor predictors. Here's phases score. Now this is for rupture, and that includes a variety of other factors. And there's a third one that's been recently presented, and that's the UIATS. But it's interesting whether it's a ELAPSE score, phases score, or the UIATS. When you take these predictive techniques and apply them to other aneurysm studies and populations, there's a big area of uncertainty. So it leaves, if you're going to use it in an everyday situation, that leaves a lot of questions in the study. So I don't think this is yet the answer to trying to discern which patients are going to go on and rupture their aneurysm. Okay, what about symptomatic? It's unclear. And symptomatic, for the younger folks in the audience, that's an aneurysm that hasn't ruptured, but because of pressure on a cranial nerve, such as posterior communicating, the most common form of symptomatic aneurysm, that cranial nerve dysfunction is what draws the attention to the unruptured aneurysm. So that's a symptomatic aneurysm. So it's unclear whether the risk is independently higher or simply an epiphenomenon related to location. Posterior communicating has an independent higher risk, and most symptomatic aneurysms are at the PCOM location. And size, most symptomatic aneurysms in the posterior communicating location have to be big enough to press on the third nerve. So I think it's probably not a factor. But here's a summary from our chapter: aneurysm related factors, size, wall strength, stress, that includes other flow factors, location, multiplicity, growth, symptomatic, and inflammation will come up on the other side. And the stars represent the strength of the association. Okay, that were aneurysm factors. Now look at patient factors. And Roberto, is there another speaker at 8?
Yes.
Oh, okay, then I better speak faster. Okay, patient factors. Here they are. Let's zip through them. Gender: aneurysms are observed more frequently in women. Prevalence is higher, and risk of hemorrhage may be higher. Now, here's a report in 1966, which I redid in this graph in our chapter, and it shows that it's not in the younger age groups, males predominate by a significant amount, but of course later on women predominate. So the largest disparity is in posterior communicators, where females are greater than males by a huge margin. But also note that in general, anterior communicator, there's a gender ratio is reversed, and males are greater than females. And for the younger folks in the audience, this is usually in the in-service exam, that question. Age: most literature supports the relation between increased age and increased risk. Hypertension: so until recently, by that I mean the last 10, 20 years, hypertension was not thought to be a factor that was associated with ruptured aneurysms. That was mainly based on this work, the works of Stebbins, who wrote an amazing book called The Pathology of Cerebral Vessels, which I would urge, if you're interested, to individuals to look at. Then Taylor published this study based on 21,000 aneurysmal subarachnoid hemorrhage Medicare patient, and showed an increased risk with hypertension. And all of those, as I said, are observational. Now comes laboratory studies, causality. Almost all experimental models that create aneurysms involves induced hypertension. Then we come to smoking, inflammation. Cigarette smoking is strongly associated with increased risk of aneurysm formation and subarachnoid hemorrhage. And here are 3 studies demonstrating that both in vivo and in the laboratory. And I'm going to skip through some of this just to point out that Zervis and Kayat early on had suggested that inflammation was the cause of rupture. And I think most folks thought, no, that's not possible. But chronic aspirin lowers the rate of subarachnoid hemorrhage. There's imaging studies that suggest that. And there are experimental studies, as I've already mentioned. Here's, I think, pretty convincing data. As smoking has decreased around the world, the rate of aneurysmal subarachnoid hemorrhage has gone down. Here are 3 studies from Finland, England, and Canada. Now, a skeptic could say, well, no, that's because people are using the internet more. But here, I think it's not proven, but highly suggestive of causality. Okay, binge drinking, I've mentioned already. Now, here's something I'll just spend a little time on: sentinel or thunderclap headaches. What are they? That's severe headache, approximately 1 minute in duration, described by Richardson and Hyland in 1941. And then along came Gilliam, who was the professor of neurosurgery at Edinburgh, and he really coined this term and pushed it warning leak, possibly caused by a, quote, minor aneurysm tear, which to many people just didn't seem right. Because minor, I mean, yeah, I guess I've had a minor hemorrhage in the operator, soon turns into a torrential downpour. So it's hard to explain. And subsequent studies suggested that subarachnoid hemorrhage followed within 2 weeks with a peak at 24 hours. But here were the caveats that came out. All studies were retrospective. So, and patients who would say, yes, I had the worst headache in my life in the last week, the answer yes was in 5 to 40% of the population. And the concept was challenged by a GP study in the Lancet that asked patients, have you had a bad headache in the last week? And as high as 63% of the population said, yeah, I did. So hard to understand it until this study came out, which I think conclusively shows that sentinel or thunderclap headaches are real in regard to being related to aneurysm leak. So this MRI study revealed variation in the age of the clot of a subarachnoid hemorrhage patients. 14 or 12% of 127 patients had a recall of thunderclap headache before their subarachnoid hemorrhage, and 13 of the 14 revealed a minor, that is older clot, and a younger clot by a T1 flare mismatch. And overall, 34% of patients revealed a mismatch, which suggests that the warning bleeding is a real entity that occurs frequently before a major ictus. Genetics, everything in medicine today can be, appears to be related to genetic predisposition. And these are listed here. I'm going to skip that for right now. And here's a summary: aneurysm-related factors. Here are the patient-related factors, which I just reviewed. And I think we have to remember there's more to it. These are human beings. And when a patient is told that they have an unruptured aneurysm, it adds some psychological burden to the life. And it's interesting, it not only can affect the quality of life, but now it can affect insurance rates for example, life insurance. So it's kind of part of the natural history. So there's the unruptured natural history. Let me, in the remaining 7 minutes, cover the ruptured aneurysm, more natural history, mortality, primary cause of death, initial hemorrhage, rebleeding, associated complications, vasospasm, hydrocephalus, and medical complications, mainly pneumonia. And here's what the various factors causally related to death. There's the initial hemorrhage shown in yellow, then the early rebleed rate occurring with 24 hours, which Cassell thought was 4% per year, and then you have rebleeding and medical complications. But this early rebleeding of 4% appears to be an underestimation. And as I've already alluded to, this early MR scanning in the early period and studies published in 2001 found that a significant number of patients rebled in the first 8 hours. And, you know, that was totally new and is sort of an echo for what followed with intracerebral hemorrhage, so-called hypertensive intracerebral hemorrhage, which now appears to rebleed before hospitalization. So it's a real factor. And mortality is associated with grade on admission, time from hemorrhage, location, rebleeding, and I'll zip through this. Here's grade on admission by designated Hunt and Hess versus mortality. And this is highly significant in a study reported out in several, 1,000 patients approximately. Grade 1, 15%, going down to grade 5, 95%. And subsequently confirmed by Phillips out of the Mayo Clinic. Now, here's an interesting other way to look at the natural history of ruptured aneurysms. Here's a regression curve of survivals from subarachnoid hemorrhage, aneurysmal subarachnoid hemorrhage, 830 single aneurysms. And this is based on the cooperative study. You can strip out the rate constants here. So K3, 9% of the population, half-life hours. That's equivalent to grade 5. Grade K2, that's 47% of the population. Half-life days, that's grades 3 and 4. Now we come to the better grades, about 43% of the population. Their half-life is measured in months. So mortality is related to grade. Time from hemorrhage. Here's another kind of interesting and somewhat amusing observation published by Buster Alvord in 1992. He produced this chart related to predictive mortality versus all deaths, percent alive, time. So if you're in the emergency room and there's a patient there for some other reason and suddenly goes, worst headache I've ever had. So it's time 0. And the patient's, you're saying, oh, he's got to be coiled or operated on. And the patient family says, well, doctor, tell us what the chances are that he will be alive 1 month from now if you do nothing. And it turns out, in general, it's about 45%. But you're busy, or the patient's in an outlying hospital, takes the patient a day to come in, patient's family asks you the same thing. Doctor, what's the likelihood our loved one will be alive in 1 month? Well, lo and behold, it's 65%. But you're really, really busy, and or the patient was way out and didn't get referred in for 7 days, and the family asks you the same thing. What's the likelihood to be alive 1 month from now if we don't do anything? 80%. So look at this. Just by doing nothing, you can improve outcome. Now, I'm not suggesting not doing anything. This is the natural history. You need to be aware of it. And you especially have to be aware of it when you're reading papers that report certain outcomes with different therapies in which the patients may have not been seen for 1 day, 7 days, 1 month, 6 months, and so forth. Location. Here's figures we reported out. Mortality at 6 months, without doubt. Survival with multiple and posterior circulation, definitely worse. Rebleeding, 50% by 6 months. And I go through a variety of factors, but time's not going to let me do it. Just that I think it's important to know that rebleeding occurs early. It's not during the first day, and we're not seeing them. So if we're going to neurosurgeons make an impact on the overall survival of ruptured aneurysms, it's going to have to happen pre-hospitalization. And location, I've already gone into. I'm just going to show this for historical reasons. Rebleeding not only varies by location, but at the same location. So here's a first use of discriminant function analysis in neurosurgery by Richardson, Jane, and Payne. So intercommunicating artery aneurysms that point up and forward have a higher rate of bleeding than those that point forward and down. So the rate of rebleeding is different, not just by locations, but even at the same location by the characteristics of the aneurysm. Okay, long-term. Just in 1 minute, tell you that when I started these studies, the neurologists believed that if the patient survived without treatment for 6 months, the aneurysm was healed. And no, I mean, they would hide the patients, etc. And it was hard to believe. So we did this study, 1,000 patients or so, different locations at Atkinson Morley's. Here were these studies that they had published of hundreds of patients in middle cerebral, posterior communicating, lancet, carotid ligation. And I had the chance to look at those relegated to bed rest. This is just one component. Anterior, posterior communicating, start out 364, survive 6 months, 213. Here's the hemorrhage rate over the first decade. Fatal in black, non-fatal. And we developed confidence intervals and so forth. Here's another group of patients carried out into the second decade. And an healed aneurysm is a flawed concept. Here's the average yearly rebleed rate over the first 2 decades. That doesn't change. So summary, late rebleeding 3 to 5%, fatal late rebleeding 2 to 3%. I'm going to skip, well, it's kind of interesting to see that aneurysm patients, at least in that era, had diffuse vascular disease, and their expected survival, removing the subarachnoid hemorrhage deaths, was higher than the normal population, mainly related to cardiovascular disease. Late epilepsy, something we don't even think about, really high in these bed-rested patients. And why? Maybe they weren't treated with anticonvulsants. Here's the ISET, only went 1 year. So I'll just go ahead and go to the summary. Here's the summary. Intact aneurysms rupture at a rate of 1 to 2%. Multiple factors related to the increased risk, both patient and aneurysm related. Ruptured aneurysm, acute course, death related to initial events, rebleeding. Ultra early bleeding is I think now clearly seen. And in the late course, there's no healed aneurysm. It remains a threat. Rebleeding 3% per year. Mortality is increased, discounting the mortality associated with rebleeding, and seizures in the long term are a potential problem to the patient, irrespective of, but higher in middle cerebrals considerably in the anterior location. And with that, I would say thank you for listening, and I appreciate the opportunity to become a colleague in this great department.
Delighted to have you, Dick. Thank you so much. That was outstanding. I don't think we have time for questions, but I'm sure that every resident is going to read your chapter in the book that is coming in a few weeks, I guess. So thank you very much. Delighted to have you with us.
Thank you, Dick.
Thank you.
Dr. Wynn, this is Dalton Dietrich. Fantastic seeing you. Dr. Wynn and I have known each other for over 30 years, where we were in the stroke and cerebral vascular disease research areas together. And Richard, really great seeing you. And thank you for this fantastic presentation. Really appreciate it.
Good to see you, Dalton.
Yeah, good times. Yeah.
Let me stop the share and let the next person.
Okay, very good. Well, good morning. Yeah, good morning, everyone, and welcome to the Miami Project, the Grand Rounds for the Department of Neurological Surgery. The Miami Project for many years now has been interested in hooking up with the Department of Neurosurgery and developing new neuromodulation, neurostimulation studies to combine with our cell therapies and neuroreparative drugs and rehabilitation. So Dr. Brian Noga is an associate professor in the Department of Neurological Surgery, and he and his team for the last several years with Dr. Jonathan Jagged has been working on deep brain stimulation, controlling motor function in preclinical studies, and now has moved to the clinic in Parkinson patients. So Brian, thank you very much for joining us today, and I look forward to hearing your presentation on the use of deep brain stimulation to optimize gait function in brain and spinal cord injury. Brian.
Thank you. Can everybody hear me? Yes?
Yes, yes.
Okay, great.
Got it.
Let me just share my screen here. Okay. Yes, thank you very much, and good morning, everyone. Today, I'd like to speak on recent progress in the use of deep brain stimulation to optimize gait after brain or spinal cord injury. As you know, deep brain stimulation is well-known neuromodulation strategy for many medication refractory movement disorders and intractable pain. It was first actually approved in 1997 to treat Parkinson's disease tremor, and then in 2002 for the treatment of advanced Parkinson's symptoms. The procedure involves the implantation of an electrode, an impulse generator for electrically modulating activity of neurons of the various pathways. Its effects are near immediate, and nicely it is reversible and can be adjusted and calibrated on a case-by-case basis. The primary requirement, of course, for its success is that there are spared connections that can conduct the signal generated by the stimulation. And here I would like to report on the use of DBS to stimulate a relatively new target that is known to initiate locomotion when electrically stimulated. This is the mesencephalic locomotor region, or MLR. So walking is produced by a central pattern generator that's located in the spinal cord. This brain activates the generator via descending pathways that originate within the brainstem. In the mid-1960s, a Russian group discovered that electrical stimulation of an area within the midbrain can initiate and sustain a locomotor rhythm. By stimulating this area in decerebrate animals walking on a treadmill, they found that they could control the initiation and speed of locomotion by adjusting the stimulation strength or frequency. And this can be seen here in this particular movie that I have. You can see an animal transition from walk to trot to gallop as the stimulation strength actually is increased. Now, this midbrain site has been found in all vertebrate animals tested to date, including mammals, amphibians, reptiles, and fish. As this site is defined physiologically, however, the anatomical correlate is based on the final electrode position. Now, the original description of the MLR had the MLR corresponding to the cuneiform nucleus, and beneath that, the subcuneiform region. But the cholinergic peduncular pontine nucleus, or PPN, has also been suggested to be a component of the MLR. This is a series of slides which I'll show you our concept of the descending pathways for initiating locomotion from this particular site. Here you can see at the very bottom of the connectome that locomotion is produced by a central pattern generator, a group of interneurons that are interconnected together on each side of the spinal cord and to each other to produce an alternating rhythmic response in flexors and extensors of the hind limb or the leg in humans. I'm sorry, I got this. All right. The MLR activates this central pattern generator for locomotion via the reticulospinal pathway. And this pathway descends through the ventrolateral funiculus to the spinal cord and then projects onto the interneurons located in the lumbar cord. Now, you can cool to block synaptic transmission within this particular part of the brain in the midline in the reticulospinal area, and this blocks MLR evoked locomotion. Alternatively, you can also cool in the ventrolateral funiculus to block fiber transmission, and this also blocks MLR locomotion. And this then identifies the descending pathway location to the spinal cord. Multiple neuromodulatory pathways are also activated by the MLR. The neuromodulatory pathways that shape pattern and frequency are monoaminergic, and they exist and come from the locus coeruleus, subcoeruleus caulicle fused nucleus, as well as the raphe nucleus, this being catecholinergic and this being serotonergic. In addition, the MLR also activates the cardiorespiratory centers, either directly or via the neuromodulatory nuclei. So this is in preparation for a bout or ambulation, and this increases the responsiveness of these neurons and the activity of these neurons to produce an increased cardiorespiratory output. Finally, the MLR is in direct connection with the periaqueductal gray, which is just adjacent to it. And this particular area of the brain is involved in defensive behavior. And lastly, the subcortical inputs are responsible for activation of the MLR to initiate the processes of locomotion. Now, a homologue of the MLR has been observed in humans. And this is indicated here, which shows the changes in blood oxygen levels during mental imagery of standing, walking, or running. Now, the corresponding location of the MLR in the cat is indicated by this black oval, and it nicely overlaps the increased oxygen utilization during imaginary running in humans. This has prompted an enormous interest, of course, in the possibility of targeting the MLR for gait disorders, such as those found in Parkinson's disease, as well as spinal cord injury. Now, the gait dysfunction in Parkinson's disease is manifested as freezing of gait and associated with postural instability. In spinal cord injury, it depends upon the level and severity of the injury, and it ranges from very mild deficits to complete paralysis. If capable of walking, spinal cord injury patients, they walk slower, they have increased rates of oxygen consumption and decreased strength, and with variable levels of weight bearing. And patients also present with severe limitations in walking speed, a decreased range of motion, and a distortion of intralimb coordination. Now, the pathology disrupting locomotion differs between PD and spinal cord injury. In Parkinson's disease, the brain's ability to turn on the locomotor command pathways is disrupted. Additionally, there is evidence for pathological changes even at the level of the midbrain, where a loss of cholinergic and glutamatergic neurons is observed, both within the pedunculopontine nucleus as well as the cuneiform nucleus. In addition, there's a very well-documented loss of dopaminergic and noradrenergic neurons in subcortical and brainstem areas. On the other hand, in spinal cord injury, there is an interruption in the connection between the higher brain centers and the spinal generators for locomotion by a lesion at the spinal level. Now, of the various approaches to help regain walking after spinal cord injury or Parkinson's disease may be physical therapies, pharmacological therapies, or electrical stimulation. And the noteworthy approaches here within this particular group are DBS, as well as spinal cord epidural stimulation, or electrical or epidural stimulation, or ES. And I will discuss a little bit about this at the very end of the talk. Now, there are several brain targets that one can choose for DBS depending upon one's desired outcome. For example, the ventral intermediate nucleus of the thalamus has been used to control tremor. On the other hand, subthalamic nucleus stimulation can be used to improve motor symptoms such as tremor, rigidity, and fog or freezing of gait. The globus pallidus interna also is affected in treating bradykinesia, rigidity, and tremor. Now, of course, I have mentioned that clinicians are interested in stimulation of the MLR to treat fog. Electrical stimulation of cuneiform nucleus induces locomotion in almost all animals tested, and stimulation of the PPN is also reported to produce locomotion and has been suggested to be the anatomical correlate to the MLR. And evidence in favor of this hypothesis has been presented. For example, the PPN receives a dense inhibitory input from the globus pallidus, and this has been hypothesized to produce akinesia by inhibition of the PPN. In humans, hemorrhagic lesions to this area of the brain leads to gait initiation problems, where stimulation of the PPN can reverse this. Furthermore, the pathological changes in cholinergic neurons of the PPN are found in patients with advanced Parkinson's disease with associated freezing of gait, as well as in aged monkeys rendered Parkinsonian by MPTP intoxication. So this has actually prompted an interest in targeting the PPN for freezing of gait. Now, there's been a fairly large number of studies examining the utility of PPN DBS for fog. Here's an example of the promising result of stimulation of the PPN in a PD patient. In the pre-op state, the patient has extreme difficulty in timed up and go or tug test, and this can be seen here. And then the patient has difficulty in proceeding forward, and then as well has difficulty in turning. This type of problem is basically making the patient feel like the Parkinson's disease is controlling their life. So it's a very, very disabling problem. Now here's the after implantation and programming of the DBS electrodes and stimulating the PPN. And it is a significant improvement in forward walking as well as turning. So this is a really beautiful example of a successful implantation and treatment for freezing of gait. Now, while these results are impressive, there have been many studies, and a lot of these studies have reported mixed outcomes with little or no improvement in fog. And a recent meta-analysis of the current data suggests that PPN deep brain stimulation may provide only a small benefit for postural instability and fog. And there are several explanations that have been proposed to account for an absence of larger effect. First, there may be significant species differences in MLR function, particularly given our bipedal gait and the dominance of our cortical spinal tracts. And these differences may have relegated the functional role of the MLR in human gait, such as DBS of this region may not have the same effects in humans. Another possibility is that there is a significant loss of neurons within the MLR in PD, and the stimulation of this region differs from that seen in intact animals. Thus, this limits the efficacy of the DBS. A third scenario is that the PPN is not the optimal target. Now, in the cat, Takakusaki et al. Have reported numerous times that the best electrode placements are found within the cuneiform nucleus, as was first described in 1966. Here you can see the electrical activity, the EMG activity produced by electrical stimulation in different parts. And a beautiful example here of locomotor activity with cuneiform stimulation. And as one proceeds further down, there is a loss of this ability to produce any kind of locomotor activity. So, and they've also found that stimulating further down in the PPN rather produces actually a muscle atonia, which shuts off the hind limb extensor activity. Stimulation in the area between the cuneiform and the PPN produces a mixed response of locomotor activity and muscle atonia. And basically, we've seen this in our animals, the animal will lay down on its side, but moves its limb in a walking-like fashion. While our own results in cats are in full agreement with Takakusaki, we have also examined this using a large animal, the pig, where we use human DBS electrodes in order to test efficacy of MLR stimulation. For testing in freely moving animals, subjects are harnessed into a manual treadmill with reflective balls that are markers on major joints bilaterally. Then we assess the speed, EMG, and kinematics data that we acquire from this locomotor activation. Here you can see that MLR stimulation is highly effective in initiating locomotion from rest. This is seen here in C, which plots the speed of locomotor animal for individual trials of MLR deep brain stimulation. In D, we plot the average trials from this animal, and these plots will compare locomotor speeds obtained with DBS to that observed during spontaneous locomotion or voluntary locomotion. E illustrates the average maximum speed for 6 animals with MLR DBS compared to voluntary locomotion. And this shows the powerful nature of MLR stimulation over that driven by the animal itself. As in other animals, the most effective sites shown here in green and in blue are found clustered in the cuneiform nucleus, and poorer responses or no effect are observed with stimulation within the cholinergic PPN or more ventral areas. In the human, a meta-analysis of numerous studies show the most efficacious points lay within the cuneiform or subcuneiform area. Note that in this slide, the orientation of the human MRI images are flipped so that the cuneiform is placed beneath the PPN up here. Now, the most convincing evidence identifying the anatomical and neuronal target for MLR DBS comes from optogenetic studies, in which the channel rhodopsin can be introduced into specific cell groups and can be used to depolarize the neurons with the application of light via an optical fiber. Initial studies, optically stimulating the MLR neurons transfected with channel rhodopsin show beautifully controlled locomotor activity. This can be seen here in this movie. With the application of the light, the animal runs very beautifully. So what neurons that are in this area are the ones that control locomotion? Well, there are 3 major cell types in the MLR. They're glutamatergic, cholinergic, and GABAergic, and they're intermingled. Glutamatergic neurons within the MLR will initiate locomotion from stop. And this can actually be seen here where we plot the speed of the locomotor activity or of the animal. And here we stimulate the glutamatergic neurons, and the increase in speed is dramatic with optical stimulation. And this is from rest. If an animal has ongoing walking, when you stimulate the glutamatergic neurons, it increases speed also quite dramatically and shuts off when the stimulus is off. In contrast, when you activate GABAergic neurons, you actually basically stop ongoing locomotion. And cholinergic neurons do not initiate locomotion at all, and it will slightly modulate ongoing locomotion when stimulated. So what glutamatergic neurons are producing locomotion? There are both glutamatergic neurons within the cuneiform nucleus as well as the pedunculopontine. So optogenetic mapping studies have revealed that cuneiform glutamatergic neurons are the ones that produce locomotion beautifully, and that varying the intensity or the frequency of stimulation will result in the ability to control the speed of locomotion from walking to trotting to gallop. Now, PPN glutamatergic neurons, on the other hand, may modulate locomotion or possibly be involved in slower exploratory type locomotion, where there are lots of starts and stops. And this has been seen in some studies, but not all studies. And it does require that the stimulation in the PPN glutamatergic area has high frequency and long duration stimulation before the effects are seen. And this has prompted some to say that the speed of locomotion actually, which is rather much slower than that seen with the capabilities of cuneiform stimulation, that it may be exploratory type of behavior, which is actually being controlled by stimulating of this area. Now, interestingly, however, there's a new study by Sylvia Arber's group in Switzerland, and they've shown that glutamatergic PPN neurons are responsible for control of body movements other than locomotion. And this may actually explain in part the difficulties and challenges of electrical deep brain stimulation of this area for movement and gait related disorders. So stimulation, for example, of PPN neurons, which are projecting to the substantia nigra pars reticulata, elicit grooming or handling behavior. Now, if you block those neurons, this inhibits these behaviors from occurring spontaneously. And during spontaneous grooming or handling behavior, the activity of these neurons actually goes up dramatically. On the other hand, stimulating PPN neurons that are projecting to the spinal cord would have collaterals to the reticular formation in the medulla, elicits body extensions and rearing. And if you block these neurons during spontaneous rearing, this will be inhibited. And then cells, activity of these cells during the naturally occurring behavior goes up in activation. On the other hand, stimulating of neurons that are projecting to the reticular formation in the medulla will elicit locomotion. Most cells of this type are found in the cuneiform nucleus. So these results have led us to propose that the true target for MLR deep brain stimulation should be cuneiform nucleus. And we therefore propose the use of cuneiform stimulation in a pilot study of PD patients. And this was funded internally by the University of Miami, as well as the Boston Scientific. This study is a collaborative effort with the departments of neurosurgery, as well as the Miami project and departments of neurology, with Dr. Jagged as the principal investigator. So the design of this study is that it's a prospective, non-randomized, single-arm, open-label pilot trial to evaluate safety and feasibility of stimulating cuneiform for alleviating fog in postural instability and gait difficulty predominant or PIGD subtype Parkinson's disease. And we have 4 PD patients with non-levodopa responsive freezing of gait. And the design, we will detail the accelerometer assisted gait assessments at pre-op and at 2, 6, 12, and 24 weeks post-operatively, with no stimulation or left-right unilateral stimulation or bilateral cuneiform stimulation. The objectives are to assess safety and efficacy, and to determine optimal stimulation parameters to maximize gait performance while minimizing any other potential side effects, and to evaluate the effects of this on other PD symptoms, including pain and quality of life. Now, the primary endpoint is to assess change in gait speed with or without bilateral cuneiform deep brain stimulation. Our primary outcome measures are percentage change in gait velocity, change in the Unified Parkinson's Disease Rating Scale Part 3 on-off stimulation across the study. And our secondary outcome measures are percent change in freezing of gait questionnaire and change in EMG amplitude during gait testing at the end study. The study was approved by the Human Subject Research Office and the US Food and Drug Administration, FDA. And this is an investigational device exemption as a phase 1 trial. So initially, potential subjects are screened by inclusion and exclusion criteria. Then several evaluations and assessments are made and informed consent obtained. There's a new neuropsych evaluation, a suicide severity rating, clinical gait assessment, and the Unified PD rating scale. After the baseline assessments, surgical screening is made, and then follows surgery with implantation and programming testing at the different time points. Our inclusion criteria are ages between 40 and 75, have to have stage 3 with good response to levodopa in the on-medication state, except for severe gait disorder. And PD stage 3 with severe gait dysfunction and predominant axial symptoms, and the score of more than 12. And then freezing of gait that's refractory to levodopa at more than 600 milligrams. Minimal tremor, bradykinesia, and rigidity symptoms are well controlled with levodopa. And of course, they have to agree to a 6-month participation. Exclusion is people that have major executive dysfunction or dementia, the presence of major medical comorbidities, transcranial magnetic stimulation or electroconvulsive therapy that's required for follow-up, and in individuals with prior intracranial surgery, and individuals with non-MRI compatible metallic implants, or anybody pregnant, and so on and so forth, and individuals on investigational drugs or other interventions that may have an impact on the outcome. So the study was initiated just prior to COVID pandemic, and despite this, we were able to complete the study on 1 subject, and this was published in a case report in Frontiers in Human Neuroscience. For this study, we used Boston Scientific directional electrodes with physical characteristics that are shown here on the right. Also here is shown the impulse generator and controller. And the electrode has a tip contact and a ring electrode, tip contact here, and a ring electrode at the top. And between these are 2 rows of 3 electrodes equally spaced from each other, in which we can stimulate separately or together. And this is seen a little bit more detail in this slide. So by individually selecting the contact, we can effectively change the direction of stimulation. This allows us to steer the current in a particular direction, useful to mitigate side effects that are produced by stimulation of off-target structures in the brain. And by programming the stimulation, we are also able to stimulate in ring mode. And this is more akin to the traditional DBS stimulation paradigm. So the electrode is very, very versatile. So here's the first patient was recruited and is a male 66-year-old diagnosed with Parkinson's disease 6 years prior, had difficulty in writing, had right hand stiffness, progressed to gait difficulties the following year, initially responsive to levodopa, and then the gait problems worsened and resulting in falls and becoming refractory to levodopa medication. The subjects issues are primarily axial. And in our multidisciplinary evaluation, we included the psychological testing and evaluation, and we did preoperative imaging. During surgery, we had surface electrodes for EMG, placement in the head frame, a CT scan, microelectrode recordings and stimulations along the trajectory while recording EMG responses and or local field potentials. to observe any off-target effects. And then the DBS electrode is implanted at the optimal site, which elicited leg oscillations on both sides. We implanted the impulse generator, obtained a CT scan postoperatively, and then continued with our gait assessments beginning at 2 weeks. Now, this slide shows the possible side effects of off-target stimulation. In our subjects, we found that the most significant and least tolerable effect was oscleopsia, which is here. And this could be with medial longitudinal fasciculus or trochlear nucleus nerve stimulation. And the subject did report that there was shaking of the visual field. So this was observed with stimulation above certain thresholds and did not really appear to dissipate with time, and no gross movement of the eyes was observed. But we could reduce the side effect by changing the direction of stimulation. And then we were thus able to actually double the stimulation current and focus the effect to the cuneiform. Now, since the nuclei comprising the MLR are reticular structures and are not easily visible, we did diffusion-weighted imaging on the subject 1 week prior to the implant. We used 3T MRI sequences and diffusion tensor imaging. Image processing was used, done by BrainLab software to correct for any kind of distortions and cranial distortions within the human brainstem. And we estimated the tractography of various structures within the brain. And these are superimposed onto the MRIs to guide the targeting. Now, these postoperative imaging slides here reveal accurate positioning of the leads at the desired targets. And they show different views of the directional electrodes for planning as well as their final positions. So here we can see the cuneiform nucleus in red here adjacent and the electrode coming in right next to it. Now, so the implantation of these leads was uneventful, and we did not have any surgical complications. The subject did, however, experience falls after surgery, continued to do that, but neither he nor the family members considered these to be above the prior baseline. Here we compare the subject's baseline, the timed up and go gait test and turning test, as well as gait parameters during 2-minute walk test, to those at his 6-week post-operative visit. That's after 4 weeks of deep brain stimulation that are on. So significant improvements were seen in the timed up and go and in the turning test, except for counterclockwise turning. That showed a trend towards improvement, but it did not actually reach significance. So gait and turning parameters during the 2-minute walk test with DBS showed significant improvements in stride length and velocity with reductions in gait variability as measured by gait cycle time and cadence, and the phase coordination index. Notably, turning time and steps per turn decreased significantly. So interestingly, the subject substantially increased the length of walking each day and stated that his legs feel like they, quote, want to go. So here is our baseline and post-implant turning test that we have as a video. This is the baseline. And then 6 weeks post-surgery, deep brain stimulation on. So that was a very significant improvement. Now this is turned off. So the subject clearly has difficulty in completing the pirouette. So now, can MLR deep brain stimulation be used to treat gait problems following spinal cord injury? And this has not been done as of yet, but our initial results using the translational large animal model of spinal cord injury are promising. We use the same MRI-guided stereotaxic targeting of the MLR with intraoperative EMGs shown here for the different electrode. These are the responses for the different electrode stimulations. We characterize and program the stimulation parameters in the freely moving animal and monitor the EMG activity as well as kinematics. And then finally, the animals are given a mid-thoracic spinal cord contusion injury. And here in this particular intraoperative sequence of EMG profiles, we can see that stimulating electrode 1 and 2, which produce the best locomotor response. And these are found closest to cuneiform nucleus. So following injury, the animals lose their hind limb function and they require weight support using a sling. With time, there is a partial recovery of hind limb function with some irregular hind limb steps, but with diminished range of movement. Now, deep brain stimulation improves the regularity of hind limb stepping as seen here for joint angles during voluntary as well during MLR deep brain stimulation. Additionally, we see improvements in EMG output, the stepping frequency, and interlimb and hind limb coupling. We then see increased joint excursion during stimulation and hip height, although we are unable to produce non-weight supported locomotion in a severely injured animal. So as an additional strategy, then we examined the use of epidural electrical stimulation in combination with MLR deep brain stimulation. And here we see the implanted epidural electrodes placed over the upper lumbar segments and the EMG responses to stimulation of the different leads intraoperatively. And once we implant, we will test the stimulation of the spinal cord, the MLR, or both in a freely moving animal. And here we found that a combinatorial approach improves locomotion the best. And this can be seen in this slide where we show electrical stimulation here, lumbar ES, MLR stimulation, and a combination of the two in comparison to spontaneous or voluntary locomotion that's initiated by the animal itself. So the raw EMGs are shown here, and then in B, C, and D, we show differences between different conditions of hip height, joint excursion, and normalized locomotor speed. And the regularity of locomotor activity can be seen in panel E, where we show that the forelimbs and the hind limbs in voluntary locomotion are indeed uncoupled, and that this can be mitigated with either MLR stimulation or spinal stimulation or a combination of the two. And here in panel F, we show the interlimb coordination as determined by cross-covariance coefficient analysis of each of the stimulation conditions compared to control. And they are highly significant. So we see improvements in a number of different parameters when we combine the stimulation, and these seem to be better in combination than they are with stimulation of either spinal cord or MLR by itself. And comparing the effects across animals of similar injury severity, MLR-DBS significantly increased walking speed and hind limb stepping frequency, as well as interlimb coordination. And that can be seen here. Here's MLR. Walking speed is improved over that seen in spontaneous, and the stepping frequency. Lumbar epidural stimulation increased EMG amplitude, as seen here, and improved hind limb coordination, as seen in here. Combined stimulation resulted in a more significant increase in walking speed, EMG amplitude, stepping frequency, hip height, and maintained improvements in interlimb coordination. And on the basis of these results in the translational large animal model, we would expect to see gait improvements with either strategy alone, and even more in some parameters when used in combination. So in conclusion, our research is providing, this research is providing a new understanding of descending pathway for initiation of locomotion. The structure of the main regulatory node for locomotor control found within the midbrain, and the functional roles played by the different components of the MLR. And this complex nature of the MLR with an intermingling of different populations of neurons that are functionally distinct may explain in part difficulties and challenges of stimulation of this area for movement and gait related disorders. So appropriate targeting of the MLR improves gait in Parkinson's disease and spinal cord injury. And it is essential that we get this correct, because once you've implanted, you don't take the electrodes out. So I would like to thank my collaborators and the funding. In my lab were 3 individuals: Francisco Sanchez and Luz Villamil, who are still there; Stefano Chang, who is a PhD student, graduated, who's now at the University of British Columbia, neurosurgery. And then in our pig study, Jan Oprist, James Guest, Juan Solano, Andrea Santamaria. And in the FOG study in Parkinson's disease, in addition to Jim Guest, as well as Stefano Chang, Jonathan Jagged, Ian Kahijas, Eva Widerstrom-Noga, Ishtam Haq, Letitia Fisher, and Cornelu Luca, and our funding from NIH and Department of Defense and Boston Scientific. And with that, I'd like to thank you for your attention.
Thank you very much, Brian. Great talk. A lot of progress, both in the preclinical and the clinical arena. Any questions for Brian this morning? So Brian, the Parkinson study is still ongoing. Any word in terms of new recruits for that particular?
Well, we actually had a person that we had thought we were going to be implanting this month, but there were some issues that were brought up with regard to the safety of implanting, and so we actually did not recruit this individual. So we're still hoping to be able to get more people over the next few months, but it's actually quite difficult, especially in COVID times. So we shall see.
Great. In the chat, can you tell us a little bit more about the optogenetic stimulation studies in animals? You plan on doing additional studies, or what's the future for that approach to looking at circuit function in a living animal?
What, in our lab?
Yes, in your lab. Let's talk about that.
Yes, so we would like to be able to continue our work in smaller animals than the rat or the mouse. What we have in plans are to actually make to actually measure glutamate release within the different target areas within the brainstem by stimulation of the different parts of the mesencephalic locomotor region to actually firmly tie up the this aspect about what cells are being activated during initiation and maintenance of locomotion, either with stimulation or with spontaneous locomotion. The other area that we're investigating is the use in collaboration with Dr. Sakrat Kirzriov from the main campus. We are looking at the possibility of using a magnetic stimulation of this area so that this would be non-invasive stimulation, which would potentially replace the implantation of deep brain stimulating electrical electrodes. And this is with injection of what's called magnetoelectric nanoparticles, which can activate neurons in the presence of an electrical field or magnetic field. And this has been shown in culture to activate neurons. And we're right now doing a number of experiments with injection and stimulation with magnetic pulses. And we've seen some promising results. The one issue would be, of course, that in order to anchor these particles after injection into our target areas, we would have to use possibly some kind of immuno tagging, put some antibodies on there to bind them to the target neurons. And but that's a possibility according to Dr. Kirzriov. So we're kind of making progress in this particular area. And of course, our electrode stimulation studies in the pig with modeling of the MLR stimulation is also ongoing with our new DoD funding. So that's what we're doing right now.
Great, thank you. Yeah, that's a really exciting direction right now. These magnetic nanoparticles that would allow you to almost non-invasively approach different deep brain areas and stimulate them. And there's some studies going on the campus on using this technology in worms right now and actually directing their movements and things. So it looks like the basis for the use of that is really good. I just wonder, can you just a couple of sentences about your new DoD funding and what you're going to be doing the next several years?
Right. So we got an expansion grant based on our previous grant from the DoD, and this work is to develop a model of stimulation using finite element modeling techniques. And it's basically a more advanced type of stimulation methodology. We try to use specific stimulation of different oriented axons relative to the electrode. And one can actually, by changing the configuration of anode, cathode, for example, one can activate fibers that are actually in parallel or in cross section to the electrode. So we think that we can target specifically different oriented fibers, which would then be a way of possibly being more specific in our electrical stimulation protocol. And in this way, we're trying to develop a stimulation model for this particular part of the brain that can be used to control stimulation in human deep brain stimulation applications. So that's the goal of the project, and hopefully we can devise a way of specific stimulation for the different oriented fibers. And maybe make a difference with respect to the application of DBS in humans.
Very good. Very good. Well, thank you again. I think this is a very exciting direction for the project. We're bringing in multiple faculty from biomedical engineering in the Lois Pope Life Center to collaborate with our scientists, clinicians. So if anyone's interested in hooking up with any of our new engineers, please let us know. So with that, thank you very much, everyone, for joining us. And again, Dr. Nguyen, thank you very much for a great presentation today. Great seeing you. And everyone have a great day. Thank you.